Today is the session of lecture series organized by ECG study group, ECG Basic and Beyond. And today our presenter is none other than Dr. Azizul Hoque sir. He will give us lecture on TOA abnormalities. Before the start of the lecture, I'd like to request Professor Atahar Ali sir to say some words about Azizul Hoque sir, and then we'll proceed for the lecture. Atahar Ali sir.
Thank you, Tushar. Good evening, everybody. আজকে আমাদের ইসিজি স্টাডি গ্রুপের প্রেজেন্টার হচ্ছেন ডক্টর আজিজুল হক। আজিজুল হক ভাই ইউএসএ তে কনসালটেন্ট কার্ডিওলজিস্ট, ভেরি ইমিনেন্ট কনসালটেন্ট কার্ডিওলজিস্ট. He works in Emory University of Medicine, that is the School of Medicine, Atlanta. উনি এই ফোরামে যথেষ্ট পরিচিত, এর আগে যথেষ্ট লেকচার দিয়েছেন, আমরা তার লেকচারটা খুবই এনজয় করি। আজকে উনি কেস বেস কিছু ডিসকাশন করবেন, একটা স্পেশাল টপিক, দ্যাট ইজ দ্য টিওএ অ্যাবনরমালিটিজ ইন ইসিজি। আমার মনে হয় সবাই খুব উপকৃত হবে। আজিজুল ভাই, ওয়েলকাম।
আসসালামু আলাইকুম সবাইকে। জাস্ট অনেক গুড ইভিনিং এন্ড এখানে গুড মর্নিং। So let me start the discussion without delay. Okay. আজকে যে আমাদের লার্নিং অবজেক্টিভ ছিল সেটা হলো কি যে এই যে টিওএফ অ্যাবনরমালিটি আমরা যখন দেখি, so what's the physiology of the T waves? We need to understand that. When you understand the physiology, then we'll be able to figure out what's the abnormality there, why it's positive, why it's negative, what's the clinical significance of that. So we'll definitely review different types of T waves. We will review also clinical common scenarios that changes with T wave morphology. And also we'll focus on the importance of understanding the differential diagnosis of T wave abnormalities. আচ্ছা, আমাদের এই তো কোয়েশ্চেনস অ্যান্সার একটা ফর্ম আছে না, থাকবে, দেওয়া যাবে? Can you put a question answer?
কোশ্চেন অ্যান্সার আপনি কি ইন্টারেক্টিভ করতে যাচ্ছেন? তাহলে তো আমার মনে হয় যে
হ্যাঁ।
আচ্ছা, তাহলে তুষার।
ওকে স্যার, পুল অন করতেছে।
জি।
কতগুলো আমার বেশ কিছু প্রশ্ন থাকবে ইন দ্য ফিউচার। আমি জাস্ট আমরা দিস ইজ ফর দ্য our trainee physicians. I like to see what they are and how much focus I need to put it on. Okay. আচ্ছা, আপনারা আনসার করুন সবাই। প্রশ্নটা হলো কি যে টিউএফটা যখন ইসিজিতে আমরা দেখি, মেজর কোন ফেজটা এবং কি আয়নটা ইম্পর্টেন্ট এই টিউএফ ফর্মুলেশন আর কি।
কোশ্চেন কিন্তু দেখা যাচ্ছে না।
প্রশ্ন দেখা যাচ্ছে না?
না।
বড় স্ক্রিনটা দেখা যাচ্ছে না?
Sir, question 1 visible.
দেখা যাচ্ছে তো? ভিজিবল না?
Question 1 visible.
ওকে, প্রশ্ন দেখা যাচ্ছে। হ্যাঁ,
কামল ভাই, পোলটা স্টার্ট করেন।
পোল স্টার্ট হচ্ছে তো, ওটা আসতেছে তো।
কামল ভাই, am I audible?
অডিওবল?
হ্যাঁ, অডিবল। অলরাইট, ওকে। সো আমরা যেটা ইনফরমেশন পেয়েছি যে এখানে দুটো অ্যান্সার আসছে, সি এবং ডি আর কি। হ্যাঁ, সো সি আর ডি তে যেটা অ্যান্সারটা আসতেছে যে ভেন্ট্রিকুলার রিপোলারাইজেশন ক্যালসিয়াম ইজ দ্য ইম্পর্টেন্ট and ventricular repolarization potassium is the important. দুইটা pretty much বেশিরভাগ এসছে সিটা হলো ক্যালসিয়াম কিন্তু, আর ডিটা হলো পটাশিয়াম। সো এইখানে কি জন্য আমি এই জিনিসটা করলাম, আমি দেখতে চাচ্ছি যে তাদের বেসিক আন্ডারস্ট্যান্ডিংটা কোথায় আছে। হ্যাঁ, সো ডেফিনেটলি উই হ্যাভ সামথিং টু শেয়ার, দেন আই উইল টক লিটল বিট মোর অ্যাবাউট দ্যাট। সো বেশিরভাগ অ্যান্সার করেছে যে রিপোলারাইজেশনটা ঠিক আছে, তারা এভরিবডি ইজ কারেক্ট, দ্যাট ইজ দ্য রিপোলারাইজেশন ফেজ। কিন্তু আয়ন চ্যানেলটা তারা ক্যালসিয়ামটা বেশিরভাগ 58% দিয়েছে, আর রেস্ট অফ দেম দে ডিড দ্য পটাশিয়াম। সো আমি ব্রিফলি, আমি কত ডিটেলে যাব না আজকে, যেটা আমাদের অ্যাকশন পোটেনশিয়াল এটা cardiomyocyte action potential that is definitely different from pacemaker cells অথবা skeletal myocyte cells অথবা neuron cells. They are different because they have a very nice plateau phase. That's the cardiomyocyte, very specific for that. এবং এটা প্রথমে যেটা আফশুটটা সেটা হলো একটা রেস্টিং মেমব্রেন পোটেনশিয়াল। আমরা যখন দেখি যে মেমব্রেন পোটেনশিয়ালটা আমরা নেই, you need to make sure you understand that it is recorded inside the cell, not outside the cell, inside the cell. কারণ আমাদের সেলুলার লেয়ার যেটা থাকে, they're very impermeable from electrical gradient because electrical gradient is controlled by different kind of voltage gated channels or different kind of ion channels. So it's inside the cell. So inside the cell is negative. Then when it starts depolarizing, then sodium ion goes in and it just shoots in at a certain level, and the threshold potential reaches, it overshoots, okay? And then very early drop in action potential we see, that's we call phase 1. The potassium starts going out. It's called outward current. That's why when the sodium goes in, it makes the inside of the cell positive and the outside negative. And when the potassium goes out from the inside cell outside, it's outward current, then the action potential starts dropping. And then at the same time, the calcium ions goes in. So potassium is going out, and calcium comes in. But calcium is a very slow channel. It causes a very plateau phase, very slow phase. That's a net change in electrical gradient is the same. That's why we see not much change in this phase. It's called plateau phase, but it's mainly predominantly due to the calcium channel, okay? Opening of the L-type calcium channel. Then you see sudden drop. Then you see sudden drop in action potential. That's the phase we are focusing on. And look at that, the ECG, how it looks like, coincides what level it is. The T wave falls in the repolarization phase, okay? So people who answered repolarization, that is correct. But what ion channel is there? The ion channel is mainly there because it is outward current, outside, okay? That is rectified potassium channel, RNS, rectified potassium channel. So potassium goes out, and that's a positive ion goes out from inside the cell to outside. That inside the cell, it becomes negative, significant drop in action potential. That's the repolarization phase, okay? And that creates your T wave. So people who are correct about repolarization, those who answer the calcium, no, calcium stops here. Calcium stops here. So because the T wave, main predominant ion is the potassium channel, okay? Rectified potassium, not the calcium. Yes, it is correct repolarization, but it's not calcium, it's potassium. So that's we need to understand it.
Aziz bhai, can I ask a question?
Yes, please.
What is happening in plateau phase? That is, the calcium is coming in or going out?
No, in plateau phase, if you remember this phase 1, okay? That's the phase potassium is going out. It's called outward current. Potassium is inside the cell. Sodium is outside, right? Too much potassium is inside. So potassium goes out. That's why it's dropping the action potential because as we know that we are recording action potential inside the cell. When the positive ion goes out from inside the cell outside, the inside of the cell is becoming negative. That's the initial drop. At the same time, there's a voltage-gated L-type calcium channel opens up. And calcium from outside goes in, but it's a slow channel. And that kind of balances out because one charge going out and calcium is going in. Potassium is going out, calcium is going in. But it's a slow channel, and that they reaches kind of steady state phase. There's no change in gradient of the electrical gradient. That causes the plateau phase. Okay, predominantly it's a calcium. Okay, predominantly calcium channel, but slow potassium is going out. Because that balances out. But at this level, at this end of this plateau phase, voltage channel calcium stops. It stops. There's no further calcium. Mainly predominant, I'm talking about. Then the rectified, potassium channel open up. Then too much potassium goes up very quickly. That drops the, repolarization potential that we see the phase 3, and then it reaches, resting potential. Okay. let's go further. The main question arises right now. Look at that. We see there's a question about, okay, so sometimes some people like question around, okay, in the repolarization phase, action potential when goes up, we see positive deflection here, right? But why the repolarization phase and the action potential inside the cell goes down, why the T wave is still positive? Why they're in the same direction? That's a dilemma always, okay? Let's sort it out, how we can understand it, okay? So as we know, when you have action potential propagation, okay, from the upper chamber, the P wave, and then slowly through his bundle, it goes down through the septum and through both ventricle that we depolarize the ventricle. But as you understand, and correctly, that depolarization starts in the endocardium. Endocardium is there's the Purkinje fibers here that starts the endocardium. It goes towards the direction of the epicardium. Endocardium to epicardium. That's the way the direction of the depolarization happens of the ventricle. But in conventional way, we can think about how it happens in skeletal muscles. If the depolarization goes in this direction, slowly depolarization will start behind it. That's the way, conventional way. After cell is depolarized, then you will start the depolarization behind it. And that's the conventional way in skeletal muscle or neuronal cells. But it doesn't happen in cardiac cells. Cardiac cell has a very different property. That's a very fundamental understanding of that. Because, and reason is why it happens, depolarization happens epicardium to endocardium. Not like depolarization happens from endo to epi, that's a depolarization, okay? But repolarization happens the opposite direction, from the epi to endo. Why? Let's dive into that. Okay, the main reason it does, because epicardial cells and endocardial cells, they have different electrical property, okay? And as we understand, the endocardial cell, they have larger action potential. Their duration of the action potential is longer. But epicardial cells, they have shorter action potential. That's the fundamental property that makes the repolarization happens in the opposite way. Normally, it happens, repolarization always in other cells, it goes behind the depolarization. But in cardiac myocytes, it happens opposite way because of the duration of the action potential is different. Endocardium is longer and epicardium is shorter. And why it happens, let's dive into that. Look at certain section of the heart muscle. I'll take one section of the heart muscle and let's go to the cellular level, okay? As we understand, when you put the electrode we put like lead one, as for example, okay? Lead one, we put it here and we go to the left side, from right to left, okay? So and the right is negative and the left side is positive. The surface electrode that we put in, they do not see the current inside the cell. They do not see that. They see only extracellular current, okay? They see that, positive, they see that, but they don't see what's happening inside the cell because the surface electrode that reflects on the ECG, okay? So imagine that our depolarization of the atrium happened, okay? Now the impulse goes down to the ventricle and we're expecting the ventricular depolarization first, right? So how the depolarization happens? As you know, the sodium level goes from the outside to inside because initially it is a negative charge inside. So sodium is going to go from outside to inside. That's the way the depolarization wave will propagate this way, okay? Let's see few cells, how it does. Okay, now we see the sodium bhitore jacche, cellular bhitore jacche, and cell inside the cell is becoming positive, outside becoming negative because a lot of sodium is going inside the cell. And because action potential is recorded inside the cell, so action potential goes up, okay? That doesn't reflect, that's not the truth with the EKG that we do, surface EKG. Surface EKG depends on extracellular electrical gradient that I'm going to explain to you. If you have any question, you can ask me, but let me try to explain that. So what happens? So sodium bhitore jacche, bhitore charge positive hocche, বাইরে negative hocche. Let's see a couple of cells happens, okay? Next cell depolarized. সোডিয়াম ভেতরে যাচ্ছে, ভেতরে পজিটিভ হচ্ছে, এইখানে নেগেটিভ হচ্ছে। এখনো এই সেলগুলা, পরের সেলগুলো এখনো ডেপোলারাইজড হয়নি। হ্যাঁ, আমার ডেপোলারাইজেশন ওয়েভ এদিক থেকে এন্ডোকার্ডিয়াম থেকে এপিকার্ডিয়াম দিকে যাচ্ছে, তাই না? তাহলে এক্সট্রা সেলুলার এখানে নেগেটিভ, এক্সট্রা সেলুলার এখানে নেগেটিভ, ধরেন মাঝপথে বোঝার জন্য easy to understand, and other cells are still positive because they are not still depolarized yet. তখন কি দাঁড়াচ্ছে? look at this line, okay? Here negative, and there's a positive. As for example, now there's a gradient of extracellular electrical gradient between the cells. The line they go in, there's a gradient, negative, positive. তখন হয় কি, extracellular electrode দেখছে যে এদিকে নেগেটিভ, এদিকে পজিটিভ, then the vector starts rising because electrode here is positive electrode, here is negative electrode. So from here to here, then we see initial depolarization, positive wave. That's the QRS. Okay, that's the extracellular QRS. Okay, let's go further. এখন আমার ডেপোলারাইজেশন হয়ে গেল সেলগুলা। হ্যাঁ, আমার ডেপোলারাইজেশন কমপ্লিট। As for example, all are negative extracellular because all cells are depolarized. Okay, এখন আমাদের conventional way we think about, okay, we'll start depolarizing from here, but it doesn't happen because, as I said earlier, that epicardial cellular action potential shorter, so they start quickly depolarizing from this direction to this direction, this direction to this direction. So let's see how it happens in a couple of cells. যেমন এটা আগে বলেছি যে এটা লঙ্গার অ্যাকশন পোটেনশিয়াল এন্ডোকার্ডিয়ামের জন্য, এপিকার্ডিয়ামের shorter action potential. Okay, all right, now let's look at how the repolarization happening. Okay, happening from epicardium to endocardium. Take a couple of cells. Okay, so how repolarization happening? Potassium goes out. So potassium যখন goes out হয়, too much potassium goes out, তখন হয় কি, সেলের ভিতরে নেগেটিভ হচ্ছে কিন্তু বাইরে পজিটিভ হচ্ছে। Let's see couple of cells. সেলের ভিতরে নেগেটিভ হচ্ছে, বাইরে পজিটিভ হচ্ছে। এখন এই সিচুয়েশনে খেয়াল করেন, আমার ইলেকট্রোড আছে বাইরে, সারফেস ইলেকট্রোড এখানে নেগেটিভ, এইখানে সারফেস ইলেকট্রোড পজিটিভ, ধরেন এটা এখানে আছে, ধরেন একটা আর্ম লিড, হ্যাঁ, লিড 1, তখন হবে কি, এইখানে দেখো নেগেটিভ চার্জ আসছে, এইখানে পজিটিভ চার্জ, and they see the direction of the vector from negative to positive. That's why the electrical axis is there. So from negative to positive. So এই লিডটা যেখানে আছে, তখন এখানে আমার টিউবটা পজিটিভ হচ্ছে। That's the mechanism of similar direction of the T wave and QRS, despite that they're different phase of depolarization and repolarization. কারণ হচ্ছে এখানে ইলেকট্রিক্যাল গ্রেডিয়েন্টে কিন্তু যখন এখানে পজিটিভ হচ্ছে, তখনই গ্রেডিয়েন্টটা তৈরি হয়ে যাচ্ছে তখন। হ্যাঁ, তখন নেগেটিভ থেকে পজিটিভ দিক দিয়ে ইলেকট্রিক্যাল অ্যাক্সেসটা যাচ্ছে, এদিকে যাচ্ছে। হ্যাঁ, একই দিকে যাচ্ছে, যেটা ডেপোলারাইজেশন যাচ্ছিল একই দিকে, কিন্তু এইটা তৈরি হচ্ছে আফটার দ্য গ্রেডিয়েন্ট ইজ ক্রিয়েটেড। কারণ এখানে দেখেন, আমি ব্যাক করছি, এইখানে ছিল সব নেগেটিভ, তখন কিন্তু আইসোইলেকট্রিক ফেজ, তখন কোনো গ্রেডিয়েন্ট নাই, কোন দিকে ভেক্টর যাবে কোনো ডিরেকশন নাই, তখন এটা আইসোইলেকট্রিক লাইন। দ্যাটস দ্য কিউটি। ওকে, এসটি সেগমেন্ট। হ্যাঁ, কিন্তু যখনই গ্রেডিয়েন্টটা ক্রিয়েট হচ্ছে, এই যে রিপোলারাইজেশনের সময় পটাশিয়াম আউট হয়ে যাচ্ছে, বাইরে পজিটিভ হচ্ছে, তখন এই নেগেটিভ and positive, there's a gradient from negative to positive, এই ডিরেকশনে কারেন্টে যাচ্ছে, that reflects your positive T wave. I hope it is clear. If you have any question, you can ask me. Okay, all right, now let's talk what types of T waves normally we see. Very short, everybody you know, like tall T wave মধ্যে দুটা মেজর জিনিস দেখতে পাচ্ছি। একটা হলো টেন্টেড means very peak but tented, narrow based and pinpoint. হ্যাঁ, আরেকটা হচ্ছে, এবং সাধারণত আমরা টল টিউব বলি যখন লিম লিডে at least 5 millimeter or more, or a precordial lead at least 10 millimeter or more, the amplitude. হ্যাঁ, আর tall broad T wave, they're tall but the base is broad. হ্যাঁ, এটা ব্রড টিউব বলি। হাইপার অ্যাকিউট টি ওয়েভ, যেমন এটা সাধারণত আমরা দেখি অ্যাকিউট ইসকেমিক কন্ডিশনে, এসটি সেগমেন্টের সঙ্গে ভেরি হাইপার অ্যাকিউটলি ইট গোজ আপ। ওকে, তারপর ডেফিনেটলি ইনভার্টেড টি ওয়েভ আছে, যেগুলো আমি এক্সাম্পল দেখাবো। তারপর বাইফেজিক টি ওয়েভ আছে, যেগুলো নর্মাল টার্মিনোলজি আমরা ইউজ করি। one thing that we need to tell you, very important concept of that, biphasic TUF, actually biphasic TUF, every TUF is determined by the terminal component of the TUF. If the TUF and the terminal component is positive, then we call it positive TUF. If the terminal component is negative, we call it negative TUF. Let's look at that, how normal TUF happens, okay? This kind of example of normal TUF, little bit, asymmetric, okay? Slightly, it take to slow uprise, and then this next segment is a little bit sharp, okay? But it's another variant of TUF, little bit, still is a little bit asymmetric, broad-based, and the second component is sharp, but it could be a little bit elevated, J-point elevation, jeta boli ar ki, it is a normal variant of those TUFs. যখন হাইপারক্যালেমিয়াতে আমরা কিরকম দেখি, very pinpointed, narrow based, little bit narrow এখানে compared to wide based, okay, narrow and little bit sharp but pinpointed, like দুইটা কোন একটা মিশেছে একটা ইসের জায়গায়, যে বোঝা যায় যে একটা pinpointed জায়গা আছে, যেটা হাইপারক্যালেমিয়াতে আমরা অনেক সময় দেখি। হ্যাঁ, হাইপার অ্যাকিউট টিউবে সেটা সাধারণত দেখতে হবে যে হাইপার অ্যাকিউট টিউবে সাধারণত থাকে যে there is a component of ST elevation or depression, okay? So ওই জিনিসটা খেয়াল রাখতে হবে যে ST-টা elevated কিনা, এবং সাধারণত they are broad based, হ্যাঁ, they are not narrow based like that, হ্যাঁ, but they could be tall, হ্যাঁ। Hyperacute tube normally say acute ischemia, যেটা STEMI MI আমরা অনেক সময় দেখতে পাই সেটা। তারপরে নেগেটিভ ইনভার্টেড টিউব, we talked about biphasic অথবা এটাও biphasic, হ্যাঁ, এবং এটা বিভিন্নভাবে হতে পারে, ফার্স্ট নেগেটিভ এন্ড সেকেন্ড পজিটিভ, টার্মিনাল পজিটিভ, এই ধরনের biphasic টিউব আমরা দেখতে পারি। Just to have an idea what kind of TUF we can see on the ECGs. যেমন পোস্ট ইস্কেমিক টিউব, হ্যাঁ, আর অ্যাকিউট ইস্কেমিক টিউব, যেটা হাইপার অ্যাকিউট একটা বলেছি, আর ইনভার্টেড টিউব যেটা বলবো, সাধারণত সিমেট্রিক টিউব, দে আর লাইক সিমেট্রিক অর ফ্ল্যাটেন্ড টিউব, হ্যাঁ। The range from flattened TUF, যেটা সাধারণত 1 millimeter up and down আমরা বলি flat TUF, হ্যাঁ, আর more than deeper যেটা বলি deep TUF inversion। এখানে হচ্ছে কি যে ইনভার্টেড TUF একটা জিনিস মনে রাখতে হবে, they do not mean acute ongoing ischemia, they do not mean it, okay? But it could rather come after an episode of ischemia. Just by inverted TUF, শুধু inverted TUF দেখে আমরা বলতে পারবো না যে পেশেন্টের অ্যাকিউট ইস্কেমিয়া হচ্ছে, হ্যাঁ। But if they had an ischemic event earlier, then it could be follow-up TUF inversion, that's a possibility, yeah. আর যদি ongoing acute ischemia, যখন আপনার TUF inversion is associated with ST depression or ST elevation, যেটা hyperacute ST elevation তো থাকে, association, আর যদি ডিপ্রেশন থাকে, যেমন এখানে ST ডিপ্রেশন আছে, ওই ডিপ্রেশনে যদি TUF inversion হয়, that could be ischemic TUF, okay? So you need to look at that in order to call it TUF inversion ischemic, whether there's an associated ST abnormalities there, or otherwise it could be old ischemia, it kind of transformed into negative TUF as a process. Okay, cardiovascular, cerebrovascular injury, like internal intracerebral hemorrhage, we can see deep TUF inversion, gigantic we call it sometimes, okay? Hypertrophic cardiomyopathy, we also can see deep TUF inversion. Sometimes it's associated with ST abnormality, we call it strain pattern, but inevitably they have very tall wave along with that, very tall R wave along with that, because they have hypertrophic heart muscles, very tall R wave, and they have associated ST TUF, we call repolarization abnormality, অনেক সময় like pericarditis, myocarditis, they might have some TUF inversion in the long run, but that's an ongoing process, because they have initially a concave type ST elevation, then it goes down, then it starts this TUF inversion. It's a process. So it might you might see that after 1 or 2 days of acute perimyocarditis, okay? So secondary TUF inversion, যেটা আমরা দেখি শান্ত বান্ডেল ব্রাঞ্চ ব্লকে, লেফট ভেন্ট্রিকুলার হাইপারট্রফিতে, হ্যাঁ, this is secondary TUF inversion, LVH, ST abnormality, যেটা আমরা repolarization, we বলি যে secondary repolarization abnormality অথবা strain, Right bundle branch, similar thing can happen. Pre-excitation, you can see some tube inversion. Right ventricular hypertrophy, same as LVH. You can see in right precordial leads, similar secondary to ST abnormality, you call it strain pattern. Okay. আরেকটা জিনিস এটা খেয়াল রাখতে হবে যে post stem, the evolution of ST elevation and tube inversion is very important to understand that for our trainee physicians. As we mentioned, in acute phase, that started the occlusion of the artery. You can see hyperacute T waves. There are some slight ST elevation you'll see. Maybe you'll see some slight ST elevation, hyperacute T waves. Then the whole ST starts rising. Whole ST, this point starts rising. Okay, that gives you ST elevation. Okay, and then in the subacute phase, you can see some ST goes down. T wave starts inverting. And if the patient really didn't get any proper therapy, quickly stented or something, they might lose some muscles. You might start seeing some Q wave. So these are the things that you see, and they can lose R waves, okay, total Q waves, this evolution of state, okay. If you don't do anything and this transmural MI, then the patient sometimes have persistent ST elevation that could be, aneurysmal ST. JQ একজন আমাদের trainee, please can you comment on the EKG? This is a 30 years old, presented to ED with persistent chest pain over 24 hours and lightheadedness. Look at the age, duration of the chest pain, and what the symptoms the patient came, and how the EKG looks like. Let's comment on that, and we'll go from there. Anybody can, trainee, please feel free.
কামরুল প্লিজ ওদেরকে কানেক্ট করেন।
হ্যাঁ, যে কোনো প্লিজ, কারণ আমরা একটু ইন্টারাক্ট করি, কারণ আমরা ডিসকাস করবো এই ইসিজি গুলো আর কি। And এগুলো very common ECG that we'll be able to see. Okay, I'll give 10 seconds, otherwise I'll start.
Anyone can please raise your hand. Raise your hand, we'll connect you.
Okay. All right. So let's start then. Okay. So let's see the ECG. This is a very common ECG that you'll see in your everyday routine. So you need to familiarize those situations of the ECG. Okay. So definitely it's a sinus rhythm, maybe slightly bradycardic, rate is about 50, axis is okay. All right. And look at that. There's probably LVH to some degree. Okay, there's some few criteria of LVH. Okay, and look at that. The T wave definitely is upright and a little bit taller than normal, right? So is it an abnormal T wave? And look at that. There's some ST elevation if you look at that. Okay, so and also V1, V2. There's some ST elevation. Is it an STEMI? That's the question you need to arise when the patient comes with chest pain. Okay, then you look into the whole picture of the patients. Okay, what's the likelihood the patient might have acute coronary event? Okay, now patient is young, and look at the risk factors. So it's, at least hopefully he's not cocaine abuser or some drug abuser. Otherwise, and look at the duration of the pain. It's 24 hours. Like it's persistent pain. It's not like come and go. And if the patient has persistent pain and it's acute STEMI, we'll see some, secondary, we call subacute phase of the ST changes. So then you need to look for other cause. Yes, the patient has LVH. Then you need to look for, so you might rule out by clinical scenario, it may not be the acute coronary syndrome. Okay. Then you look out what are the other cause of this type of ST elevation. Okay. Patient has LVH. Yes, with LVH, we see secondary ST abnormality. But look at some J point, we can see that elevation, J point elevation, and it's a concave type, ST elevation. So early repolarization is probably top priority in diagnosis of this patient. Okay, so it is early repolarization, and look at that. Look at the proportionality of the T wave, taller T wave, the amplitude of the T wave. It is proportional. Look at that, how deep the S wave is up to that level, and the proportionality of the T wave. Definitely, the T wave is smaller than the S wave. So they are normal proportional for the LVH. Okay, if this T wave is way up than the S, then you have concern about whether it's acute event happening. Okay, so look at that proportionality of the S wave and the T wave. If it is proportional for the LVH, it's deep S wave, and you will see some T wave abnormality with that. So it's taller than normal, but it is likely due to the LVH. And we have some criteria. Look at the S wave, view R wave, look at the S wave. You add that up, more than 35. You can do that, almost 21 AVF. So there are several criteria for LVH on these patients. The patient has LVH, sinus bradycardia, and early repolarization pattern. So the patient doesn't need to go to the cath lab. And definitely need to talk to the patient and see what's the risk, or repeat the ECG. If the pain continues, then you need to figure it out. But definitely the patient doesn't need to go to the cath lab for that ST elevation.
Azizul,
All right.
Azizul,
Yes.
do you want to check the troponin in this patient?
It could most likely be normal. Okay. But the question right now, if you do, for other reason, as for example, the patient comes with severe hypertension. Okay, because I have a feeling of that he might have underlying hypertension with that much of LVH. Okay, so severe, if the patient comes with 180 blood pressure, okay, then you do the troponin, it might be elevated because of the endomyocardial pressure, just a pressure of the tiny capillaries on the endocardium that it pushes the pressure that can release mild troponin. But that troponin is usually very mild. You can do another set of troponin in 2 hours. In the emergency room. If you see no significant rise, a flat, mild troponin elevation, you can ignore that. We call it type 2 troponin, most likely for severe hypertension. Okay, that's the diagnosis you need to put, not acute coronary syndrome, type 2 troponin elevation due to acute severe hypertension. That's a scenario could be possible, yes. But if it's without any reason, most likely troponin will be normal, okay? All right, let's look at the second case. Anybody want to, I don't know if anybody enthusiastic. I'd like to get interactive. Let's say trainee physicians, please raise hand. It's not that difficult. But you need to, reason is if you say that, your peers look into that and how to interpret the ECG. I'd like you to interpret the ECG. Anybody, 10 seconds I'm giving. Anybody raise hand?
I think anyone can
LVH.
participate.
Sir, it might be LVH, most likely HCM patient, apical variant, I think.
But yeah, LVH is correct. And it could be hypertrophic cardiomyopathy. There's a possibility. We cannot exclude that. But the one question I have, this T-wave inversion, okay, like you see that above the baseline, right? There's a ST elevation there, but it's a J point elevation, okay? But it's proportional, deep S wave, and the T-wave is not that high, not more than S. And there's significant LVH, and there's we call it strain pattern or secondary repolarization. There's a deep T wave. So that's not due to acute ischemia. That's not due to probably cerebral, clinical scenario. You have to look at that patient came with epigastric pain. I don't think so. It's a cardiac pain. It's epigastric pain. And if the patient is not having STEMI, there's no reason to take him to the cath lab. Yes, there's some ST elevation, but they are J point elevation, okay? And deep T wave inversion, but that's proportional to the high tall amplitude that is secondary repolarization pattern. Okay, so this T wave, you need to look at that. It will be very common with severe hypertension or hypertrophic cardiomyopathy. You're right. Okay, let's look at the next case. 45-year-old with 3 hours of chest pain and diaphoresis. Okay, anybody can pick it up, please.
From the participant, I'm seeing that there's a raised hand from Dr. Tanmoy and Dr. Asif.
Yeah, please try to answer that.
Respond.
Please connect them, Kamrul.
Kamrul bhai, can you make them audible?
Ojoy?
Okay.
There is a okay.
Yeah, Ojoy is participating. Yes.
Okay, please, huh? Yeah.
There is ST elevation in V1
Uh-huh.
as well as into V2 and V3
Uh-huh.
with slight flattening of ST depression in lead AVL and as well as in lead 1. I think this might be a case of ST elevation MI. Most likely it's the first differential in my.
Okay, that's correct. And let's see a few points I like to make on the ECG, because the reason I showed a normal ECG like early repolarization pattern before, and let's see what's the difference between these two. Okay, so here you can see J point, right? It could be early repolarization here, okay, but this kind of proportionally a bit way up the ST elevation here. This is definitely way up, okay. But the major differentiating point, look at the S wave, S depth of the S wave, and the amplitude of the T wave, ST and T wave, they are almost equal. That's the disproportional, we call it T wave abnormality, T wave elevation, okay? ST elevation or T wave.
Can I add a
yes, please.
Actually, shrinkage of QRS is one of the indirect sign of acute ischemia, acute MI. I think that's correlates with your comments. Shrinkage of QRS corresponding to the shrinkage.
And this is correct. And আপনার যদি wide হয়, left bundle branch হয়, then you know that your ST elevation will be there. Then you need to go to Escarbosa criteria or modified criteria, those type of definition there. But they will be more prominent V1, V2. But V3 lead, when you have that high, and also there's a clue, V1 leads some ST elevation there. That is a big clue. And second, even if it is not there, but look at that, QRS duration, rightly pointed out, narrow, okay? And the depth is depth, and this depth from here to here, almost equal, probably T wave is more than the depth. That's called this, disproportional long, tall T wave. When you see disproportional long, tall T wave, then most likely the patient is having hyperacute ST elevation, just starting, okay? So and definitely this patient had a CAT, we see that is total LED occlusion.
Azizul, please, can you back to the previous ECG, please?
Yes.
In V4, V5, V6, that is a clear J point elevation, but V1, V2, V3, এখানেও তো elevation আছে, কিন্তু এখানে J point elevation বলছেন না কেন?
Now, the question right now, in the J point elevation, when you look at that, here, when you see that notching, it could be J point elevation, but the question right now, look at the notching. When you say notching, you confidently say it's a J point elevation, you understand? Here, but the patient might have some early repolarization pattern before, but now it's having ST elevation on top of that, and this notching probably gone here where they had it before. I don't know, okay? But definitely, it is elevated, okay? And though we see concavity here, but we'll see if you do the EKG, it's just starting. We don't see the ST elevation that far yet. We see the early elevation. If you see 10 minutes later, this ST elevation is going to go to concave type, okay? Right. This is the early peak of the T wave. But if you wait 10 minutes later, you need to repeat the EKG in patient if the patient doesn't go to cath lab that quickly. The patient went too quickly. We didn't have any intermittent EKG, but definitely that ST elevation is going to go up. Then you see classic ST elevation.
I think the additional clue is V1 as well.
Yes, absolutely, because we already have some clue here. That's the ECG I chose on this patient to understand, because similar looking like early repolarization, but three important difference I'm pointing out again. Clue is V1 elevation. Second, disproportionality of the tall wave compared to S wave, and narrow QRS that somebody pointed out here. So these are the important points you need to make in distinction, and also definitely clinical scenario. The patient having chest pain, diaphoresis, you cannot rule out. Okay, then you do the
what about ancillary?
What about there's some reciprocal just ST depression there. Yes, there's some clues there. Okay, all right. Any other comments? I like to get interactive discussion that we understand better. All right, let's go to the next one. This patient had stent in the LED, and this the this the ECG changes. Any comment on that from the? Is it abnormal or normal? from the trainee, anybody can comment, okay?
Okay.
The post PCI.
Yeah, this post PCI,
post
right?
post ischemic.
Yeah. Now, yeah, we call it a reperfusion injury, a reperfusion pattern of the T-wave abnormality. Okay, this is not abnormal because they are reperfused. Because if you see on the next day you do ECG and ECG looks like that bad, okay, but it's not bad. It's just reperfusion. So keep in your mind, post PCI, this type of ECG is normal. Okay, but if the patient did not have PCI, patient came with this ECG to your emergency room,
Yeah.
then you are very concerned. Then you're very concerned the patient is Whelan syndrome, okay? Acute, proximal LED occlusion in and out going on. And I'm going to talk about that later on. But I need to keep in mind, post-PCI, this type of T-wave abnormality is common. It's reperfusion T-wave abnormality, you call it, okay? Let's do another is.
If
I
the
have to
patient
comment.
has ongoing chest pain with this ECG change, we should have to think again whether there is any problem in the stent also.
Now, if there's ongoing chest pain, yes, that is correct, okay? That's I'm telling you, clinical scenario is very important, but if the patient is doing okay, then it is reperfusion, okay? All right. Let's look at this. Anybody want to comment from their trainee physicians? Raise hand. 40-year-old with history of CKD came to ED with vomiting, okay? It should not be that difficult. Anybody can raise hand. Just we need to describe how the T-wave looks like, or this broad, narrow, peak, tented.
Narrow peak tented T, suggestive of hyperkalemia.
Yes, okay. So the patient, definitely there's a clue there, there's CKD and ED come with vomiting. So imagine that it is also tall T-wave, right? The difference is that they're a little bit narrow-based. They're narrow-based, and they're tainted. They're very peaked. They're very peaked. Okay. In the hyperacute, we see a little bit broad-based, and this arm has less slope, and this arm is high slope, like sharp down. Okay. That's ischemic T-wave, tall T-wave. This is hyperkalemic T-wave. Okay. And the patient had, calcium chloride. The patient is found out has, acute renal failure, had dialysis immediately. Sorry, this is previous ECG, we found it, and we saw that abnormality there, this old EKG we compared, and this is resolution of the T-wave is gone after the potassium was corrected, okay? All right, let's do another patient, 70 years old, hypertension, pacemaker, 4 hours of chest pain and nausea, okay? And we see, anybody can comment from the, trainee physicians? Please raise hand. We'll do 10 seconds, then we'll start.
In presence of pacemaker spike and this T-wave changes, can it be due to secondary changes due to reproduction abnormality?
Okay, let's discuss that, okay? First of all, what we see is atrially paced, right? It's not ventricularly paced.
Ventricle is
When
not.
the ventricularly, it's not V-paced, A-paced. So it has normal conduction, okay? So atrially paced, but normal conduction, okay? So that you have known is not due to the pacing, so something else going on, okay? Patient having 4 hours of chest pain, nausea, okay? And look at that, few things here. Look at that 2-3. There's some elevation there, okay? It's still not quite yet. It still doesn't meet the criteria of STEMI yet, okay? Look at that. There's some. You need to ask question about that. What's going on here, okay? And look at that. 1 in AVL. There's a ST depression. That's a major concern you have. Not only that, V1, V2. Some ST depression, not V3, V1, V2, okay? Still, a patient came to the ER, still debating when the patient needs to go to the cath lab because STEMI is still not called yet, okay? So the main concern is right now, but we have some concern. Clinical scenario is there, so that's you cannot ignore. Concern is ST changes 2 to 3. There's some question about, but it still doesn't rise the ST elevation enough to call STEMI. That is true, okay? But V1, V2 ST depression on 1 AVL, that will keep you very, very high alert. So follow these patients. You might not call the, team yet, STEMI call yet, but look at that. And we had a previous EKG on these patients. And you see, that's pretty normal looking, okay? 2, 3, normal looking, okay? The old EKG we compare. So we knew there's something wrong going on. We were on high alert on this patient, okay? And look at that. Waited 10, 15 minutes, trying to discuss, call the cath team whether we need to go in or not. There's some changes occur. You see that some hyperacute changes happening in lead 3 and lead 2 some, but look at that new ST depression happened on 3, V3, that we did not have it. Okay, and the one in AVL, ST depression a little bit deepened. Okay, so then we call it STEMI because then this hyperacute phase, that is the things it should not miss. Always think clinical scenario, the pain is going on, okay? And you repeat the ECG because sometimes you might not see in the initial EKG the STEMI criteria, but you repeat the ECG and you'll see some criteria is popping up. You need to have a high suspicion on that and look at if any old EKG is available. You compare that. If you see certain difference, we saw some difference, we knew that there's a problem there. Okay, and there's new ST depression in V3. Now the question about whether it's inferior STEMI or posterior STEMI, definitely you need to do in this case scenario posterior ECG that will clarify that whether you have posterior STEMI. But if it is posterior STEMI, yeah, we see that ST depression V1 to V3 leads, and there's some positive TUA. But in AVL, in posterior STEMI, we should not see the ST depression. We should not see that. Okay, we see rather V5, V6, and one in AVL may see either isoelectric or elevated ST elevation if it's a posterior STEMI. Okay, because these two leads represents posterior wall, okay, posterolateral wall. Okay, so that has to be, and also the ST depression, ST elevation is more in lead 3 than lead 2. So you have several criteria. Okay, ST elevation, if it is more in lead 3 and 2, and one in AVL is negative, most likely it is right coronary.
Yeah.
Okay.
Sir, why
so there
PR is getting prolonged, sir, because of the occlusion site. PR is
yeah,
getting...
that's likelihood. We're talking about, yes. So RC is probably likelihood. We need to look into the AV node blood supply. Okay, so that might be an issue here. So yeah, definitely she has acute RC occlusion. Okay. And this post-stenting. All right. This is after the patient had a stent. Okay. Next day, when the patient is discharged, you see some TOA inversion. Okay. That's not uncommon. We call reperfusion injury, reperfusion TOA pattern. So I'm showing that in the next day when you discharge the patient home, it's a TOA inversion. So that's not uncommon. After a few days, weeks, it might normalize. Okay. So just keep in mind that if the patient not having chest pain, did fine of the stent, the next day you do ECG, then might see some TOA inversion. That's normal. Okay. All right. Let's look at that 70-year-old man with exertional chest pain lasted about 30 minutes. Okay. Let's discuss that quickly. So definitely we see some hyperacute T waves, right? And imagine that this is way up than the QRS. Okay. That's definitely disproportional. So when it's disproportional, you need to start thinking about acute event, okay? And patient is 70 years old, chest pain lasted 30 minutes. So it's hyperacute change, we already see that. But like lead 3, maybe lead V3, V4 is there, okay? So, and you're talking to the people examining the patient, wait 10, 15 minutes, look at and do another EKG, chest pain getting worse, it didn't get better, you give nitro and everything. But look at that. Now we see not only hyperacute, we see some ST depression here. I need to visualize and memorize this pattern of ECG.
And reciprocal change as well.
Yes, yes. And this is called De Winter sign. De Winter sign. Okay. You see that very classic De Winter sign in this patient happened. Okay. Hyperacute, slight ST depression. Okay. And you see De Winter sign. When you see the De Winter sign with acute chest pain, you know that proximal LAD. Okay, imagine that. You see that this pattern, you need to remember that going down and very hyperacute TOA. That's the De Winter sign. Okay. And the patient underwent, stenting the LED, and when the patient went home, we see some slight Q wave in V2, V3. It happened, and some T wave biphasic is still persisting, but they're okay. That's reperfusion T wave, we call it, and there's some small Q wave formed already, unfortunately. Okay, so that's the de Winter sign. Okay, ST depression, very hyperacute T wave abnormality. Okay, and it's acute ischemia, most often caused by proximal occlusion of the LED. So put in your memory this sign, de Winter sign. Okay, all right. Few things that I like to call it, like you saw some T wave inversion before, now it's normalizing. That is called pseudo-normalization of the T waves. What does it mean? If any known old EKG, you had T wave inversion, and the patient comes with chest pain, you must suspect myocardial ischemia. You must suspect. Okay, patient had old T wave inversion that coming to the emergency room with chest pain, and T wave is normalized. You must suspect myocardial ischemia. Just remember that is a very, very common mistake we do. If we have old EKG, you need to compare that. Okay, you cannot let the patient go home because T wave is normal. EKG looks normal. Okay, but had T wave abnormality before, you know that on old EKG, come chest pain, T wave is not normal. Because what happens when ischemia changes the action potential in the endocardial side. Because you know that I talked about that action potential. It is longer in the endocardium, epicardium is shorter. When there's ischemia, endocardium action potential, because of the ATP phased opening of the potassium channel, the action potential shortens in the endocardium, it shortens. It makes smaller. Then it reverses the direction of the axis of the T wave. Okay, it can normalize. So it was negative before, but with acute ischemia, it can be positive, normal. Okay, so you cannot let the patient go home. When you see that, you always suspect ischemia. You need to do some workup for this patient. Okay, and the rule applies regardless of the cause of T wave inversion, either left bundle branch block, LVH, pre-excitation, right bundle branch block, RVH, pacemaker, because you would expect some T wave inversion. If you see normalization of the T wave in these patients, you always suspect ischemia, and particularly with the ongoing chest pain. Okay, and definitely in left bundle branch block, pseudo-normalization of T waves in V5, V6, and one in AVL, when you expect them, the T wave should be inverted, because in left bundle branch, they should be inverted. There's no question on that. If it is positive, you suspect ischemia because of the action potential duration change, because of sodium ATP-mediated potassium channel opening. Okay, and patients who have developed T wave inversion post-ischemia or MI may actually develop pseudo-normalization of T wave if they have reinfarction or reischemia. Okay, as for example, like you have T wave inversion post PCI, now you have chest pain again, reocclusion, the T wave can be normal or upright or could be hyperacute. If you see their changes with the patient who already had event, you did some intervention, or you did not, they might have reoccluded the artery. So these are the points I like you to remember. That is very important clinical points on differential diagnosis. Okay. All right. So let's look at that. 20 years old male came with productive cough, sharp chest pain. Let's see. I'm not sure that. Okay. Let's look at that interesting case. Okay. 20 years old, has some productive cough, like some fever. Okay. Came to emergency room, had flu-like symptoms. Patient was given azithromycin. He's a student, has some depression, takes citalopram. Okay. Vital signs stable, cardiovascular exam stable. You did an ECG, ECG looks like that. Okay. Anybody from the trainee physician could comment on the ECG, very classic ECG for certain condition.
You got the type 1 pattern?
Yeah, Brugada, that's correct. Okay. So, and the main concern is that, tell me what's the reason for this pattern on this patient. Okay. Can you choose any answer? Let's see how you answer.
The fever?
That is correct. Okay, so we have very intelligent audience today. Okay, so definitely there's a question about whether citalopram is causing that. Okay, or the combination of citalopram and azithromycin. Okay, a lot of people could answer that E. Reason is combination of citalopram and azithromycin that cause QT prolongation. Here, it is not due to that cause. Here is caused a differential potential, action potential of the epicardial that causes this Brugada-like symptoms, differentiation, and fever kind of precipitates that. So answer would be definitely fever, okay? All right, let's look at another case, we'll stop. 48 years old female presented to ED with left-sided chest pain with radiation to the arm, nausea, diaphoresis, okay? Happened an hour
me,
ago,
Dr. Aziz.
remember? Yes.
Aziz bhai, excuse me, can you just hold? Actually, আজকে আমার চেম্বারে একটা পেশেন্ট আসছে ইয়াং ছেলে 20 ইয়ার্স এরকম বুজাটা টাইপ 1 নিয়ে একজন ইএনটি স্পেশালিস্ট পাঠাইছে তার টনসিলেক্টমি করবে। এখন আমরা তো জানি যে বুগাটাতে লিডোকেইন বা টাইপ 1 সি বা সোডিয়াম চ্যানেল ব্লকার কন্ট্রাইন্ডিকেটেড। এই ক্ষেত্রে আমরা কি করতে পারি? পেশেন্ট অ্যাসিম্পটোমেটিক, বুগাটা টাইপ 1 প্যাটার্ন, ওয়ান্টস টু ডু surgery. So what will be the question?
And most likely they will do fine, okay? Unless there's a precipitating factor, unless the patient is symptomatic. Okay, most Brugada, they don't have any problem, most Brugada, okay? If they have chest palpitation, they have syncope, then you need to start worried about, okay, whether the patient is high risk of cardiac arrest or not, okay? I think they will do fine with the anesthetics they normally use, okay?
Propofol,
I think that
propofol can precipitate, propofol or lignocaine can precipitate arrhythmia.
I think in Brugada, I have to look into that. I don't think so, but I have to look into that, okay? But
Okay,
you can
you.
look at that. I can give you a website. It's called brugada.org, okay?
Okay.
www.brugada.org, and you can look at that. There's a very good website there. There's interaction of the medication in Brugada syndrome, what you can use, what you cannot use. And I think anesthesiologists are very aware of that. But most people do fine with that surgical. If they don't have symptoms, you don't have to do anything. If they have symptoms, and the quinidine is a medication that might be helpful in certain situations, these type of patients. But if they don't have symptoms, don't do anything. If they have symptoms, they had cardiac arrest, then you need to think about whether the patient needs certain intervention, including prevention of cardiac arrest, ICD, and all these things, okay? But they have to be symptomatic. Otherwise, most people do fine. 80% people do fine. All right, let's do this case. 48-year-old female, but you can look at that brugada.org. They have a list of medications that has an interaction with that, okay? With left-sided chest pain and radiation to the left arm, nausea, diaphoresis. The patient has classic symptoms, okay? But the patient had chest pain an hour ago, lasted 15 minutes. Then when the patient came to the emergency room, no chest pain. Okay, and the patient reported that she had prior some few episodes of chest pain before. Okay, and patient is totally pain-free on ED, and that's the ECG. Anybody could comment on that from the trainee physicians?
Could be Wallen.
That is correct. Okay. The reason is when you see, because we are talking about a T wave abnormality, when you see that some sort of biphasic or just negative T wave, V1 through V3 leads, or even sometimes it can extend to V4. Always look at the clinical scenario. You cannot ignore this type of patients when the patient comes with, concern about acute coronary syndrome, and particularly if the patient is chest pain free. Right then, that they show the EKG, not during the chest pain. During the chest pain, they might have hyperacute T wave or ST elevation. And what happens, they occlude the artery, and we have natural fibrinolytic system in our body, they open up, okay? They occlude the artery, they open up. When they open up, they get pain-free, and this repolarization pattern, it happens, okay? So if the patient had chest pain before, like an hour, 3 hours before, come to the ED and show up with this EKG, the patient has proximal ALD occlusion unless proven otherwise, tight disease, okay? And definitely you need to take these type of patients to the cath lab. You cannot send the patient home, okay? Answer is C. And we did that, and look at that, what we have, okay, in this patient. Proximal ALD occlusion. I mean, not total occlusion, a tight disease there, because they're opening up, closing, the thrombosis. Okay, this is a type A, as you see, biphasic, V1, V2, normally you see. Type B, mainly deep T-wave inversion. That's a type A and type B. Type A, normally you see about 25% of patients. Type B, we see 75% of the patients. And the main criteria for the Walden's syndrome, that they should not have any ST segment elevation during the EKG. And they should be pain-free. Okay, no Q waves. Okay, normal ROA progression. Recent history of chest pain within a few hours chest pain. Okay, and during the examination, during the EKG, they're pain-free state. Okay, and they might have very mildly elevated troponin from previous short duration acute event, or could be normal. These are the initial EKG findings, and these are the associated information that you need to have to put in Walden's syndrome diagnosis. Now I'm going to stop here. I'm sorry, it took long. So any questions, we'd be happy to discuss.
Sir, Walden could be associated with the positive AVR as well.
Yeah, let me tell you, depend on Walden most commonly LED, but it can happen in other arteries also, because as initially when it was reported like about 20, 30 years ago. Sorry, I missed it. Okay, so that was initially the data accumulated mainly in the LED. Okay, but then we found out it can happen in inferior territory or circ territory. Okay, but they are rare. Most commonly they're LED. Okay, but main thing that you need to look into that, the diagnosis we make mainly V2, V3, those leads. Okay, those are the lists you should not miss. Other lists can happen, but those are the main criteria that the Walden's criteria we should consider. Next.
Any questions from forum, Tushar?
Assalamu alaikum, sir.
Sudhir?
Question korbo, sir.
Sure.
Yes.
So thank you so much, sir, Aziz sir, for the wonderful presentation. আমার মনে হয় স্যার আপনি যদি টিউব অল্টারনেন্স নিয়ে যদি কোনো ইসিজি রাখতেন কিংবা কিছু যদি হাইলাইট দিতেন তাহলে এটা আরো বেশি ভালো হতো স্যার। And what do you mean by loss of precordial T-wave balance, sir? এটা very important, কারণ যারা ইমার্জেন্সিতে কাজ করে কার্ডিয়াক ইমার্জেন্সিতে তাদের ক্ষেত্রে এটা যদি জানা থাকে তাহলে এটা কিন্তু অনেক হেল্পফুল হতে পারে। It's one of the earliest manifestations of inferior valence. So এইটাতে একটু হাইলাইট দিন। And আপনি একটা সুন্দর ইসিজি যেটা দেখিয়েছেন স্যার, ওইটা যে AVL এ T-wave inversion আসছিল, and subsequently we got ST segment elevation in the inferior lead. পেপারস গুলো অনেকগুলো পেপারস আছে, সেখানে বলা হয়েছে যে AVL এ ST segment depression is highly sensitive for the STEMI inferior, and it is one of the earliest manifestations. It occurs hours before the ST segment elevation in the inferior lead. So that was a very nice ECG. এবং যারা ইমার্জেন্সিতে কাজ করে জুনিয়র ফিজিশিয়ান যারা রেজিডেন্টস গুলো, ওদের জন্য এই যে ইসিজিটা দেখাইছেন, ইট ওয়াজ ভেরি ইফেক্টিভ আমার কাছে মনে হয়। যে কারণ হচ্ছে যে আমরা যদি আর্লি রিকগনাইজ করতে পারি তাহলে সেই অনুযায়ী কিন্তু আমরা পেশেন্ট ম্যানেজমেন্টে হেল্প হইতে পারে স্যার। সো লস অফ প্রিকর্ডিয়াল টিউব ব্যালেন্স স্যার, এইটাতে একটু হাইলাইট দেন, এন্ড দেন টিউব অল্টারনেন্স আমার কাছে মনে হয় যে
that's very important. Definitely, it's good comments. Let me explain to you one thing. One thing that on that EKG that particularly mentioned in AVL ST depression, যেটা হ্যাঁ, কারণ জিনিসটা হচ্ছে কি আমাদের খেয়াল রাখতে হবে যে আমাদের if you look at the three-dimensional way, which are we are not 100% correct, but we can at least guess, okay, with the knowledge we have. If it is like inferior ST elevation, then we can, there's two things can happen. With this inferior involving the posterior STEMI, okay, inferior posterior STEMI, or inferior alone. If inferior alone, then we will see posterior reciprocal ST depression. If it's inferior alone, posterior reciprocal ST depression. What are the posterior leads? A high lead, V1, V2, V3, those leads, and one in AVL. If you see ST depression there, that's highly sensitive that you mentioned, very important point. When you suspect there's a questionable ST elevation in inferior leads, you need to think about there is ST elevation. If you see that subsequently going on, reciprocal ST depression in posterior leads. Okay? যদি posterior MI হয়ে থাকে, still you might not see much. You might see lead 2 higher ST elevation than lead 3, but in one in AVL you will see positive deflection of the ST, positive, right? Elevated or at least not be depressed, or V5 V6. Okay, the high lateral leads. Okay, you might see some slight ST elevation there. One in AVL and V5 V6 ST elevation, there's a questionable ST elevation in the inferior. Think about posterior. And then you'll see also ST depression V2 to V3, but there's some positive T wave in those leads. They will be not negative. Okay, so that you can differentiate those things. Other questions?
Sudhir. Hello.
Sir, if there is
স্যার
question,
Hello, Dr. Sudhir.
জি স্যার
আচ্ছা না তুমি খুবই থ্যাংক ইউ ভেরি মাচ ফর ইউর পার্টিসিপেশন। তুমি দুটো
Yes,
খুবই
that's
ভালো-
great. Yeah.
আচ্ছা দুটো মানে তুমি আমাদের পার্টিসিপেন্টদের জন্য দ্যাট ইজ লস অফ টি ওয়েভ ব্যালেন্স এন্ড টি ওয়েভ অল্টারনেন্স এক লাইন করে বলতে পারো?
আচ্ছা স্যার তাহলে
Acha.
আমি স্যার
এক
স্যার
লাইনে
আপ-
বলো।
স্যার
Please comment on that, and I can also add. Okay, go ahead, comment on that. Mhm.
লস অফ প্রিকর্ডিয়াল টি ওয়েভ ব্যালেন্স যেটা বলা হয় স্যার যে ইউজুয়ালি আমরা ট্রানজিশন যেরকম আমরা আর ওয়েভের যে ট্রানজিশনটা দেখি একটা ট্রানজিশন জোন থাকে আর নর্মাল প্রোগ্রেশন অফ দি আর ওয়েভ যেরকম আমরা দেখি যে V1 লিডে আর ওয়েভ ছোট্ট একটা খুচার মতো থাকবে কিংবা খুবই ছোট থাকবে এবং যত যত আমরা V6 এর দিকে যেতে থাকবো তত তত আর ওয়েভ লম্বা হইতে থাকবে, এস ওয়েভ শর্টার হইতে থাকবে। দিস ইজ ফর দি আর ওয়েভ প্রোগ্রেশনও কিন্তু আমরা জানি। এক্স্যাক্টলি ইন দি সেম ওয়ে স্যার টি ওয়েভের ক্ষেত্রে বলা হয় যে V1 এ যদি তুমি দেখো তাহলে টি ওয়েভ ছোট থাকবে কিংবা অনেক সময় নেগেটিভও থাকতে পারে এবং যত যত তুমি V6 এর দিকে যাবা টি ওয়েভের কিন্তু হাইট কিন্তু বাড়তে থাকবে কম্পেয়ার টু দি ব্লিড V1। তো যদি তুমি দেখো ইন দি অ্যাকিউট ইমার্জেন্সি দ্যাট দি টি ওয়েভ হাইট ইন V1 is equal to or even greater than the T wave height in the V6, this is one of the earliest signs of the anterior valve MI. If I am not wrong, sir, আপনি যদি
Go ahead, finish, and I'll add one thing. Mhm.
স্যার এইটা স্যার আমার মানে আমি বলা শেষ করলাম স্যার আপনি বলুন।
না না না
Now, জিনিসটা হচ্ছে কি, that's more, that's accurate, but there's one question to look at that. TUF actually is related to the QRS. Can depolarization and repolarization, which are as deep you have QRS, you can expect the TUF would be taller. And we call proportionality of the TUF with the QRS. That's the terminology you use more now. আমরা যদি দেখি যে এস ওয়েভটা either সমান টিউবের সমান হয়ে গেল, then there's problem there. Then there's a hyperacuity or something going on. Because then we see the loss of proportionality of the QRS with the T wave. As you know, any like left bundle branch block, LVH, any bundle branch morphology or pre-excitation, it depends, the T wave depends on the QRS. Okay, as the depolarization goes, that goes to the repolarization phase, because we call secondary repolarization abnormality. If you lost that balance, then you suspect there's ischemia going on. Okay, as for example, like left bundle branch block, we expect TUF inversion, right? That's expected with secondary repolarization abnormality. If left bundle branch blockage, the 1 and AVL and V5, V6 দেখো, either isoelectric or positive T wave, there's a problem there.
আর এইটা
হ্যাঁ সুধীর।
স্যার আপনি ওই যে কিউআরএস এর সাথে মানে মানে এইখানে আমি বলতে চাচ্ছি যে কিউআরএস যেরকম সেরকমই মানে কিউআরএস এর মতো বড় না আর কি টি ওয়েভ যেটা আমরা নর্মালি যেটা পাই ইউজুয়ালি সেইরকমই দেখতে, কিন্তু মানে হচ্ছে যে আর ওয়েবের সাথে যেটা কিউআরএস এর সাথে যেটা বললেন ওইরকম লম্বাও না, কিছুই না। জাস্ট আমি V1 এবং V6 এর সাথে যদি কম্পেয়ার করি স্যার, কারণ অনেক সময় দেখা যায় যে নর্মাল লুকিং টিউব, দিস ইজ নট আ হাইপার একিউট অর টল টেন্টেড টিউব অর সামথিং লাইক দ্যাট। এইটা
Right.
দেখতে কিন্তু সাধারণ টিউবের মতোই, কিন্তু জাস্ট আমি যদি কম্পেয়ার করি তাহলে V1 এর যেটা T1 এর যে হাইটটা থাকবে, ইট ইজ ইভেন গ্রেটার দ্যান দি T1 হাইট হাইট ইন V6 lead, তখন কিন্তু ইট ইজ সাজেস্টিভ অফ আর্লিয়েস্ট ম্যানিফেস্টেশন অফ এন্টেরিয়র ওয়াল এমআই স্যার। এইটা আমি বলতে চাচ্ছিলাম স্যার।
No, no, I
আর
got your point. No, I agree with that. I got your
yes,
point. But
yes.
you know, this criteria is not right, not normally used in a normal convention, and that is true.
স্যার আমাল মুতু স্যারের পেপার গুলো আছে স্যার, সেখানেও আছে, এবং আরো অনেকগুলো পেপার আছে স্যার অ্যাবাউট দি transition of the T-wave
No,
balance, precordial
I'm
T-wave balance.
aware of that. I am aware of that. But
Yeah.
that those are the criteria. We have more criteria comes up, more evident criteria
Yeah, but
comes up when this
I'm just
activity
I was
happens.
just adding that it is one of the criteria so
Sure,
that
sure.
we can early. Yes.
Yeah.
And
No,
sir,
I got a point. I agree with that.
মাইক্রোওয়েভ টিউব অল্টারনেন্স ব্যাপারে যেটা স্যার বলছিলেন স্যার, সেটা হচ্ছে স্যার যে এটা হচ্ছে বিট টু বিট ফ্লাকচুয়েশন অফ দি টিউব অ্যামপ্লিটিউড এবং মরফোলজি স্যার, এবং এটা একটা ইলেকট্রোফিজিওলজিক্যাল ফেনোমেনন। এবং এইটা যদি আমি পাই যে টিউব দেয়ার ইজ অল্টারনেটিং টিউব মরফোলজি এন্ড দি ভোল্টেজ, তাহলে এটা আমরা কিন্তু আমাদেরকে জানায় যে দেয়ার ইজ ইম্পেন্ডিং ভেন্ট্রিকুলার এরিথমিয়া, এই পেশেন্ট ইজ লাইকলি টু গো টু ভেন্ট্রিকুলার ট্যাকিকার্ডিয়া, ভেন্ট্রিকুলার ফিব্রিলেশন সুনার অর লেটার। তো এইটা কিন্তু ওয়ান অফ দি আর্লিয়েস্ট manifestations of the ventricular arrhythmia, that is called T-wave alternance or microvolt T-wave alternance.
থ্যাংক ইউ সুধীর ফর ইউর
Thank you.
এবং তুমি দুটো খুবই ভালো টার্ম ইন্ট্রোডিউস করছো, এবং এটা ইসিজি বইতে টেক্সট গুলো আছে যে এই সমস্ত দ্যাট ইজ লস অফ টিউব ব্যালেন্স এন্ড টিউব অল্টারনেন্স, এবং আমরা যারা ইন্টারেস্টেড আছি তারা এই বিষয়টা গোত্র করতে পারে। এবং আমার মনে হয় যে আজিজ ভাইকে ধন্যবাদ যে এটা আরো বেশি ক্লিয়ার করছেন। এবং আজকের লেকচারের তুষার সবচেয়ে ইম্পর্টেন্ট দিক হচ্ছে কম্বিনেশন অফ দ্য ফিজিওলজি অ্যান্ড দ্য ক্লিনিক্যাল অ্যাসপেক্ট, রিয়েলি এক্সেলেন্ট লেকচার, এবং যে কারণে আমার মনে হয় যে সবাই আরো কোশ্চেন করতে ইন্টারেস্টেড হচ্ছে। আজিজ ভাই, থ্যাংক ইউ ভেরি মাচ ফর ইউর এক্সেলেন্ট ব্রিলিয়েন্ট লেকচার। দ্যাট ইজ
No. Thank you. Welcome.
একটা
This
জিনিস স্যার,
lecture,
আজিজ স্যারকে একটা জিনিস আমি এড করি স্যার, মানে স্যারের যে লেকচার গুলো যারা একটু হাই থটস এর পরে কিংবা যাদের একটা লেভেল আছে তাদের ক্ষেত্রে কিন্তু আমি দেখলাম যে স্যার বোর্ড সার্টিফিকেশন এক্সামিনেশনের অনেকগুলো ইসিজি স্যার নিয়ে এসেছেন, এবং স্যার যেটা দেখাইছেন একটা যে আরবিবিবি কিংবা এলবিবি মরফোলজিতে টিউব ইনভার্সনটা আমরা যদি খেয়াল না করি স্যার, এটা কিন্তু ইসিজি অফ দি মান্থ স্যার 2021 সালে কিন্তু আমেরিকান কলেজ অফ কার্ডিওলজি রিসের মধ্যে দেওয়া ছিল আরবিবিবি, এবং সেখানে শুধুমাত্র টিউবটা নর্মাল দেখিয়ে দিয়েছে, এবং এই পেশেন্ট চেস্ট পেন নিয়ে আসছিল, বাকি সবকিছুই নর্মাল, হি ওয়াজ ডায়াগনোজড অ্যাট অ্যাকিউট এমআই। তো এই জিনিসগুলো কিন্তু সূক্ষ্ম জিনিস, বাট ভেরি ভেরি ইম্পর্টেন্ট যারা হচ্ছে জুনিয়র কার্ডিওলজিস্ট ওয়ার্কিং ইন দ্য ইমার্জেন্সি ডিপার্টমেন্ট। থ্যাংক ইউ ওয়ান্স अगेन স্যার।
thank you. Actually, lecture who is my audience are. I'm not talking about the faculty lecture. I'm talking about the young physician lectures. That's the most impact we get. So I tailored the lecture within certain time. So they get the most important things they need to know. কারণ হচ্ছে কি যে মেকানিজমটা কি এক, দ্বিতীয়ত কেন আমরা কিউআরএস একই দেখি টিউব একই দিকে দেখি, হ্যাঁ, lot of people cannot explain that. Why the amplitude is same but the polarization phase is different. They need to know what ion is moving, because what medication you're choosing, that depends on that. Second, you need to know the common morphology of T waves, quickly diagnose what intervention you need to take. There's some subtle things that you mentioned that then we expect a T wave inversion, you see normal or abnormal a positive T wave, you start thinking about seriously something wrong. So those are the things, basic things I wanted to touch so they don't miss it, and for the board preparation, for the training and everyday work. And definitely we can go detail on certain other more things that Dr. Atahar Ali from the EP people probably could touch that more detail on those things. Okay, so I'll conclude that way. Thank you very much for that.
থ্যাংক ইউ আজিজ ভাই, এবং পার্সোনালি আমি নিজে অনেক কিছু শিখলাম আজকে। রিয়েলি এটা একটা খুব এক্সেলেন্ট লেকচার ছিল। আজকে আমাদের অনেক ডিস্টিংগুইশড পার্টিসিপেন্ট ছিলেন, আমাদের অজয় ছিল, নাহারুমা ছিল, অনেকেই ছিল। আমার মনে হচ্ছে তাদের কমেন্ট নেওয়া যাচ্ছে না সময় স্বল্পতার জন্য, বাট থ্যাংকস এভরিবডি ফর দেয়ার পার্টিসিপেশন। আমাদের ইসিসি স্টাডি গ্রুপের পক্ষ থেকে থ্যাংকস বেক্সিমকো। আর আমাদের নেক্সট প্রোগ্রামটা হবে হচ্ছে 23rd of this month। আমরা খুব শীঘ্রই সেদিনকার স্পিকারের নাম ঘোষণা করবো। এবং আজিজ ভাই, রিয়েলি ইট ওয়াজ এ ব্রিলিয়েন্ট লেকচার। আমার মনে হয় এই ধরনের ফিজিওলজি এবং ক্লিনিক্যাল কম্বিনেশনের লেকচারটা সামনে আপনি আবার আরেকটা রেডি করবেন। থ্যাংক ইউ ভেরি মাচ।
না, I think my focus is
স্যার
right now.
ফিজিওলজি পার্সন থেকে স্যার আমিও অনেক কিছুই শিখেছি এন্ড ইট ওয়াজ এক্সিলেন্ট, ব্রিলিয়েন্ট। আমি বলবো যে ফিজিওলজি সেকশন যেটা প্রথমে গিয়েছেন স্যার, ওইটা একটু স্লো গিয়েছেন, বাট ইট ওয়াজ এক্সিলেন্ট স্যার, এটা বলবো স্যার।
ঠিক আছে,
জিনিসটা হচ্ছে কি,
ক্লোজ করো। হ্যাঁ,
এটা এমনি বন্ধ করে দিতে পারেন অফিসিয়ালি। হ্যাঁ,
জি জি জি, ঠিক আছে স্যার, তাহলে আমরা আজকে সেশনটা ক্লোজ করি।
ওকে, থ্যাংক ইউ এভরিবডি। ওকে,
Everybody got that.
অনেক রাত হয়ে গেছে। হ্যাঁ,
আচ্ছা,
থ্যাংক ইউ।
ঠিক আছে।